Hello Malaysia and welcome to another edition of Medical Day. I'm Jared Ratnam, and as always the program is packed with heaps of information just for you in order to give you a better insight as to what's happening in the ever-changing medical world. Now today we start our first segment talking about generic medication. Now when you talk about generic medication, there's always an ongoing debate about it, not amongst professionals but amongst us lay people. Now, some believe that the original is better than the generic. Now, we have someone to weigh in on this. We did speak to Zulhazri Razali, the director/pharmacist from the commercial division of Pharmaniaga. Here's that interview. A little something for us to listen to and find out more about. Let's take a look at this. Zulhazri, thank you very much for joining us. Now, we want to talk about generic medicine, and when you talk about generic medicine, the understanding of generic medicine, from what we understand, is still very low amongst people outside. So when you talk about generic medicine, what is generic medication?
Okay, basically generic medicine is a product where companies produce it when the original or the patent product has become off patent. That means companies, they have the formula which can be manufactured similar to the original one, right? Maybe some people say it's a copy drug, but to me, we call it a Me Too product.
Right.
Okay. In general, the active ingredient is the same. The only difference in between generic and the original is the content of the other stuff. For example, like the coloring or the taste. Okay. Sometimes even the appearance also is the same.
The look and feel.
But in general, the pharmacological effect is the same. The indication, okay, the how it is used, okay. Even sometimes the side effect is more or less the same.
So to classify what generic medicine is, say if you have a patent on some formula, it takes 20 years for the patent to die. Why is that? Why 20 years?
Okay, companies who develop those products, they invested on average is can be $1 billion US per product over the years. So they want to recoup all those investment, okay, by introducing it to the market, and of course using WTO or maybe the world standard kind of commercial thing. They were given a certain period of time for them to sell exclusively for that particular molecule that they have invented.
Right.
So that's part of the trade agreement, the whole world, where patent product they've given certain time to sell. Right. Exclusively only for them.
So let's take, for example, a couple of different medications. Let's just say PPIs, proton pump inhibitors. Let's talk about omeprazole. So after 20 years, your gastric medication patent runs out. Now, for a company to make a generic version of it, what must a company do in order to make sure they are following the exact guidelines with the formula?
We've got a few standards in the world, British standards, United States, USP standard, and they also have Indian standard or Japanese standard. On those standards, they have a specific formula for certain molecules. For example, like this omeprazole, once they off patent, everybody knows the content of the active ingredient, right? It can be 20 milligram or 40 milligram of omeprazole. So those companies who want to design the generic, they will use those standards and look back at all the other ingredients to formulate a particular tablet or capsules, and they do series of testing so that the effect, all right, of that particular generic formula similar to the original. Right. So what I'm trying to say is the main active ingredient is the same. Other things that they add in, they will test through the labs, okay, through series of what we call testing in their what we call manufacturing facilities, so that the end results or the profile is similar to the original.
Right. For those of us who are not too clear as to the difference of these medications, we hear our friends saying, you know, you buy the original, it's better than the generic or the fake. Some people call it fake medication. And people, when they take the original, they say, oh, I think, you know, it's got better effects, the efficacy is better. Is there any truth to that? Or is it very placebo in nature where the effect is?
It's all about understanding of the whole thing, okay? And when you go out there and to look for medicine, you've got two options. You buy the original and you buy the generic. And your understanding about the generic and the person you ask for it's important also. So when you go out there, you've got to get some advice from the right channel. The pharmacists or the doctors or any healthcare professional, which they knowledgeable enough to tell you the truth. But if you ask your friends or your what we call
just your coffee shop talk friend,
they could tell you so many things.
So as a pharmacist, a trained pharmacist at that, working in a facility as such in Pharmaniaga, what would be your advice with regards to advantages and disadvantages of generic medicine? Are there, you know, should we even bring up this question in the first place?
Okay, the main thing why people look for generic medication, even lately when we heard about prices kind of thing, is the affordability, all right, and the accessibility. Compared to the original, the generic version is more cheaper and is widely available because there are so many brands. For example, like Viagra, we've got only one Viagra in the market, but we've got quite a number of generics of the same molecule, giving the same effect.
Basically, it's Cialis, isn't it?
Yes. So it's sildenafil actually.
Sildenafil,
yes,
sorry.
It's very simple molecule, but you can make it into a generic version and go through a proper procedure of registration. There you go. It's become a generic and it's very much cheaper.
Right.
So you've got to go to the right person, pharmacy or doctors to understand.
So the base component will be sildenafil. It is the same, and the efficacy would be the same too. But here's the other question. So if a patent dies out on, say, so not sildenafil, but Viagra, and there are companies that come up with something of the same nature using sildenafil, why is it that the principal drug owners not bring down the price?
Okay. Many patented items, when the generic comes into the picture, it depends on the area where they are selling to. For example, if they sell to the government, it could be cheaper because the purchasing in the government side, they're looking for affordable drugs. Sometimes they don't mind getting the generic, so the competition in that area could be huge, they can drop. But in private sector, normally they keep to their brand, all right? And to them, certain customers or certain centers, they don't mind paying at the premium price because they believe in that particular brand.
And branding is a big thing.
Branding is a big thing, even in pharmaceutical. But of course, in pharmaceutical industry, promoting or marketing or branding, they have certain regulation. You can only do it in the professional setup, like the doctors or pharmacy.
With my last question, and we've got about 2 minutes left on the show, my last question is, how do you minimize confusion between generic and the original? So is there a confusion in the first place?
If you look in general, if you don't really understand the products on the shelf, you could be what we call misguided. All right. Sometimes on the shelf you can see the original and the branded ones. For example, even like Panadol or paracetamol, right? One is branded, one is generic. Okay, but if you go deeper, when you ask questions and you seek information from the right person, you understand and you can make a well-informed decision on which one to take.
Right? Now, very quickly, what would be your personal advice to all of us buying medications?
Okay. First thing, you've got to get it from the approved channel. Don't buy at the street. Don't buy from the illegal source. you've got to get it from the approved and the right channel.
Especially sildenafil.
Yeah, because there's so many people out there trying to what we call cut corners in selling their stuff. So if you focus on that particular channel, then the next thing is much easier for you to manage.
Right. With that, we'd like to thank you very much, Zulhazri Razali, Director/Pharmacist from the Commercial Division, Pharmaniaga, Berhad, right here on Medical Today. Stay with us. We'll be back right after the break.
Ep7 menampilkan pelbagai segmen menarik khas buat anda. Saksikan 9/11 setiap Isnin hingga Jumaat 9 pagi. Hanya di Bernama News Channel.
Mengupas isu semasa, merangkumi politik, ekonomi, sukan serta hiburan. Membawakan anda agenda pentas dunia. Saksikan Ruang Bicara setiap Isnin hingga Jumaat di BNC.
Hello and welcome back to Medical Today. I'm Jared Ratnam, and as always, we're bringing you information as we move along within the hour. Now, just a while ago, we talked a little bit about generic medication. I hope you sort of have an idea now as to what generic medication versus the original is all about. From there, we move into new hybrid treatments for cancers. We're talking about interventional oncology and the new targeted options. Now, why are we doing this segment today? We want to talk a lot about liver cancer also, simply because that is one of the problems in Malaysia, which is becoming a high incidence problem. Now, liver cancer is rising for a variety of reasons, or its incidence is rising for a variety of reasons. This includes viral infections and also lifestyle. Now, primary liver cancer is what they say or call a challenging condition, and you need someone who's really good to diagnose and treat it, in part because many cases of liver cancer are diagnosed when the condition is already very, very advanced, and surgical treatment no longer offers a cure. Now enter another area of speciality we're talking about, interventional oncology and the new targeted options. Joining us is a guy who's really famous these days. He's making a name for himself, doing a lot of teaching. He's also heading a lot of associations. Dr. Alex Tang, consultant vascular and interventional radiologist from Ramsay Sime Darby Healthcare. He's joining us today. Doctor, thank you very much for joining us. It's an honor to have you here. I've heard a lot about you. I've even called some ex-colleagues of yours. They say you're a really strict guy, but you know your thing. Now you're very serious about what you do. So today what we want to talk about is liver cancer, and more importantly, when you come in, you know, when oncology is not working, you guys come in to save the day. What we want to talk about today also is liver cancer. So what is the status of liver cancer in Malaysia at this point?
Well, first of all, Gerard, thank you for having me here. I'm entrusted today with the duty of informing the public on the various options and new advanced treatment technique available in Malaysia, where the public can benefit from the treatment exercise. This what we're going to cover today. Essentially, they are available in most major hospitals, the government general hospitals, in the tertiary medical centers, in the private field, as well as in the academic center. Rest be assured that the Malaysians are among those in the forefront in the treatment of liver cancer in this region, and the public do not need to go overseas just to get the same treatment.
That's what I wanted to ask you about, because a lot of people say, oh, if there's a cancer problem in your family or someone is suffering from cancer, it's usually good to get an opinion from overseas. Do we really need that in this day and age?
Well, it depends on the situation. We can't deny that in certain situations, certain disease is very rare, and in the world, there are only selective institutions who are good with that. That is a very niche, very rare condition. But overall, in terms of the general oncological diseases in Malaysia, our local expert will be able to handle the cases with ease. And our availability of technology, the drugs, and all the treatment exercise, as well as our modern imaging equipment are also very advanced. And we are not far behind with anybody else.
That's very good news, or good to know that we are not far behind, and there's always help and good advice when it comes to targeted options with regards to oncology or interventional oncology. Now, when you talk about the risk of liver cancer, what should we know about early detection of liver cancer?
Liver cancer in the worldwide wise, is the 6th most cancer in the world, and it used to be the 3rd most common cause of cancer-related death. But I think since last year, it has taken over and become the 2nd leading cause of cancer-related death, with incidence of 746,000 cases registered worldwide. And in the Asia-Pacific region, it has registered 75% of cases. In other words, what it means is that liver cancer is mainly an Asian-Pacific disease. We see more than the West, the American.
Why is it discriminating to us?
I think the incidence is high. Basically, it's because of the high incidence of hepatitis B, the carrier rate and the transmission in this region. And of course, with the upcoming fatty disease, fatty liver is going to take over the main cause of liver cancer in next 20 years' time, when the hepatitis B is in control. I think the hepatitis B immunization program was started in 1985, if I'm not mistaken. Since then, the incidence of hepatitis B carrier has been dropping. But on the other hand, hepatitis C is also among the common cause, especially in the West, US, and Japan. And in this country, we see more hepatitis C infection among the Indians. I think there are certain probably transmission pattern.
Good news for me.
Malay and in Chinese, it's more toward hepatitis B. Of course, alcoholism, chronic alcohol consumption.
Yeah, but with alcoholism also, they say fatty liver was due to alcoholism. Now, you don't need to be an alcoholic to have a fatty liver.
Well, in my daily works, I would say when they do ultrasound, we see more than 50% of people, even young patients of the 10, 15 years old, they have bad fatty liver. This is very much related to the diet as well as the lifestyle exposure. So fatty liver is coming in and taking over a lot of this as a primary risk of liver cancer in 20 years down the line. And Malaysian has a lot of obesity, so we are really facing upcoming challenges. Well, let's go back to liver cancer in terms of this incidence of liver cancer in Malaysia. The MOH report in 2011 mentioned that liver cancer is the fifth most common cancer in among the male and 6th in the female, and with an incidence of 4,128 cases. But I believe a lot of the cases were not reported because a lot of patients has gone overseas for treatment, hence it's not recorded. Malaysia, by the WHO standard, is in a high endemic area, so it's actually much higher than that. And most of these cases are detected very late. And this was actually reported by Professor K.L. Gold in 2011 and 2015 in the study in University Hospital, where about 45% of them present very late. When they come at late stage, a lot of things we cannot do. So the whole purpose of early detection is to pick out this cancer early enough when they are very small, and the option is wide and many things can be done. We come to the option maybe a bit later.
Now, you're also the president of the Malaysia Society of Interventional Radiology, which means your work is not only treating people, you need to go out there and teach. I do understand that you run a masterclass in teaching young radiologists about the way forward with regards to interventional oncology. So what's that area of your work like? How many young radiologists have you trained?
Well, the masterclass in TAC TASE essentially is a very specialized teaching program in teaching the junior interventional radiologists from Malaysia and Asian countries in learning how to do the procedure properly, optimally, how to select the case which are suitable for treatment, how to select proper devices, and what is the treatment protocol, what is the endpoint, and how to optimize and achieve best clinical result from the exercise. So far we see a lot of places the IRs are a little bit lost by no means offend anybody. It's a bit lost on what is best and how to decide optimal treatment option. So this training program essentially is to streamline the exercise, and we have a lot of renowned faculty and teachers from Asia Pacific region who are really expert in this field, like those from Korea, Japan, Taiwan, China, Hong Kong, etc. So we are running the third session end of next week, and we don't want to train too many people at one go. 50 IR to very intensive and kind of like objective training, so that when they leave the course, they are well versed on the treatment technique and technology, and we hope from there they can train another 100 under their supervision.
We're going to take a short break. When we come back, we're going to look at treatment options for us. What are the treatment options available? Dr. Ellis will come back and discuss that with us. We'll also talk about how effective these treatments are. Stay with us right here on Medical Day. We'll be back just after a short break. Listen to views of industry captains. Analyze and examine trends and projections. Gain market insights from subject matter experts. Biz Talk every Friday only on BNC.
The Nation, a talk show from the Current Affairs desk with in-depth conversations on health, women, property, culture and performing arts. Only on the Nama News Channel.
Brings you the latest in current affairs, lifestyle and entertainment, as well as one-on-one discussions with fascinating personalities. Only on Nama News Channel.
Hello and welcome back to Medical Today. We're currently discussing cancer treatments. We're talking about interventional oncology, and in the studio with me is Dr. Alex Tang Alak, consultant vascular and interventional radiologist from Ramsay Sime Darby Healthcare. He's also the president of the Malaysian Society of Interventional Radiology. Now, when you talk about interventional radiology, it is a very niche area of speciality, and even if people know it, how experienced are them, or rather these people or doctors at it? Now, he's training a lot of people like we talked about earlier on. What we want to move into now is the various pillars of his work. There's medical, radiation, surgical, and interventional. Yeah, so let's talk about medical first.
Well, in the management of cancerous diseases, we have four main pillars. The conventional one will be the medical oncology, who use chemo drugs to treat patients. Number two will be surgical oncology, who do debulking or cutting out the tumor. Number three will be radiation oncology, who use radiotherapy to kill the tumor. With the advent of the technology since the discovery of the X-ray in 1895, the current state-of-the-art technology and the computer system allowed the X-ray equipment or other systems like ultrasound or MRI to show the organs in a split of a second, and hence it's a real-time scanning process. And for that, many new devices, miniature tool, either tube, wire, needle, and tiny, we can say
gizmos.
Yes, has been developed so that we can actually target a tumor precisely, either through the artery or the veins, or directly inserting a needle in, and that will be able to target and cure the cancer. This field is called interventional oncology. And this treatment technique has been in Malaysia for over 20 years. Okay? And is available in most public hospitals, major medical centers, tertiary medical center, and the academic center. Interventional oncology has a lot of advantages. Okay, with due respect to the other treatment technique, okay, the current trend worldwide is moving to less and less invasive procedure.
We want to create smaller holes.
Interventional radiology essentially is a pinhole surgery. Okay, and most of the time, if without tracing the record or doing a scan, we don't even know what has been done to the patient.
Right.
Essentially, the procedure is performed under the combination of an X-ray machine, either an angiogram machine or CT scanner or MRI or an ultrasound, where we can see the tumor, then put a needle in, specifically go to the area of interest and do whatever we need to do. Similarly, we can use angiogram machine we put a tiny tube, we call it catheter, and we are using smaller catheter, the size of a hair, we call it micro catheter, thread through all the arteries, and the IRs, of course, the interventional radiologist has to learn about a route map, the artery in the body, and know where the organ is. For instance, the good example would be in the liver. We track into the artery in the liver, we call it hepatic artery. And
hepatic artery,
yes, we inject a little bit of dye, and that will give us a route map. And through that route map, we are able to thread the tiny catheter with the guidance of wire to the artery super selectively and deliver anti-cancer drugs.
But here's the important thing. Of course, all of us may be thinking that it is easy because it's done, microscopic surgery is done with the help of computers. But you're wrong again. You need to know the roadmap. So basically, before, correct me if I'm wrong here, before you conduct the procedure, you need to study the roadmap to the cancerous area. Yeah, and that's done through
the angiogram.
Angiogram. So you look at the angiogram, and you need to think about what gizmos and little toys you have there with you in order to get to that area and deliver the treatments or the whatever treatments you want to deliver to that certain area. Is that how it works?
Yes. Okay. Essentially, interventional oncology has a few advantages. Number one, it's minimally invasive. Hence, most of the procedure can be done under local anesthesia, minimal pain, very fast recovery, and because it's so targeted, and even we deliver anti-cancer drug, it's so focused. The side effect is minimum. The dose is much lesser as comparing with systemic chemotherapy, and the tumor will be ablated, and the side effect is also much less. In many situations, this technique can be used as either a primary treatment option in the management of cancer, or as supplementary to whatever the other
primary or
doing.
supplementary.
Yes, okay.
But what's also very interesting here was off the air we were talking about the various ablation techniques. There's RFA, MWA, IRE. They're not rap bands. They're actually techniques to remove cancers. So let's start with RFA, using radio frequency. How does that work?
Let's come back to the liver cancer. Liver cancer, we know the best treatment is still surgical resection. But surgical resection can only be done in less than 20% of cases, either because the tumor is too big, or both sides of livers are involved, or liver function is too poor. So the other 80% of cases, if they come in a suitable stage, we can do a lot of things. Okay, as an interventional radiologist, okay, we will need to stratify them whether it's early cancer, less than 3 cm, 3 to 5 cm, or bigger than 5 cm, one or multiple. Those who are less than 5 cm and less than 3 or 5 tumor, we can do local treatment. We call it tumor ablation. Tumor ablation essentially is a needle-based system where you can insert a needle directly into the center of a tumor under either ultrasound or CT scan guidance, and from that we connect into a generator. Okay, it depends on what type of frequency we are using. If we use radio wavelength, we call it radio frequency ablation. And this energy will be focused at the tip of the needle, and it generates heat to about 100 degrees, and it burns a pre-designated area. For instance, if you use a needle with bad tip of 3 cm, we are burning a tumor with a diameter of 2.4 cm and a length of 3.5 cm.
Just taking a little bit more, just to be sure.
Okay. If you use a frequency of microwave, like those you
so microwave is MWA.
We call it microwave ablation. Microwave ablation has a better efficacy in terms of it burns a bigger area in a shorter time. But overall clinical outcome for both are about the same. It's up to the operator to strategize and optimize the treatment. These are heat-based treatment. Okay, where we bring a temperature up to 100 degrees. On the other hand, we can also cure the tumor by lower the temperature to minus 40 degrees. When the cells, the temperature in the cell drop below minus 20 degrees, they will be dead. And this we call it cryoablation.
Cryoablation means icing, freezing it.
Yes. This is what the Chinese hospital used to come to advertise about it.
Right, so they used to come and rave about it, advertise about it all the time.
And this cryoablation is available in Malaysia, that's one thing for sure. Of course, the fourth technique we can use, we can shock the tumor with 3000 volt of electricity. With that, you can destabilize the cell membrane. Yes. Okay. You destabilize the cell membrane and the cell will lyse after that.
Right.
These are, we got tumor ablation technique, direct focal treatment. Right. And this can be used up to 5 cm to treat tumor up to 5 cm. On the other hand, of course, if the tumor is too big, too many, or in certain area where it cannot insert a needle because it's too near to the heart, there are bowel in front, too close to the aorta, things like that. Then we have the other technique where we can do this interventional oncology type of treatment. We call it transarterial chemoembolization, TAC.
Transarterial chemoembolization.
Yes. Essentially what it means is that we insert a tiny tube through the artery at the groin or through the radial
femoral artery.
Through a femoral artery or through the radial artery, go to the hepatic artery in the liver. And from there, we do a root map, do an angiogram, and the IR should be able to identify where is the feeder artery to the tumor. And from there, thread another tiny microcatheter directly into the area of interest, deliver the anti-cancer drug in a high concentration, and the cancer will die.
Right.
This technique is very special in the sense that medical oncology killing a tumor by intravenous infusion of the chemo drug is just like you fly a B-52, bomb the whole area just to kill a future rival or enemy.
So it's like targeted warfare.
Yes, this is like targeted warfare, and we call it regional chemotherapy. So it is far more accurate and far more efficacious, better efficacy, and because the concentration of drug which is delivered to the tumor, you are talking about 500 to 1,000 times higher, and it show the effect far better than a systemic chemotherapy. This is TACE, and this technique has been available in Malaysia way back during my training time in 1990. So that we are talking about 30 years.
Right.
Okay.
So I guess the final question would be is how effective these treatments are. Now, we want to talk about that, but we're running out of time. So what we're going to do is definitely bring Dr. Alex back to the studio at some point to talk about the effectiveness of these treatments, because we've covered so much and there's still so much more to cover when it comes to interventional oncology. We'd like to thank Dr. Alex Tang for making his way right here into the studios. Thank you very much for staying with us. We'll take a short break and come back right here on Medical Today. Stay with us.
Nine-11 menampilkan pelbagai segmen menarik khas buat anda. Saksikan 9-11 setiap Isnin hingga Jumaat 9 pagi. Hanya di Bernama News Channel.
Gain insights from the people with the capacity to translate vision into reality. Interviews with corporate leaders at 8:30 p.m. Monday, only on BNC. Listen to views of industry captains. Analyze and examine trends and projections. Gain market insights from subject matter experts. Biz Talk every Friday, only on BNC.
brings you the latest in current affairs, lifestyle and entertainment, as well as one-on-one discussions with fascinating personalities. Only on Onawa News Channel.
Welcome to the final segment of Medical Today. I'm Jared Ratnam. We talk a lot to specialists or people from different areas of specialists all the time. More importantly, we talk to a lot of doctors, professors, so on and so forth. But no one takes into consideration what happens in the day of the life of a nurse, and their days can be very, very hectic. I know of a lot of doctors who are very dependent on nurses because the nurses know the job better than some of them, or at least this is what we hear on the ground. Now, for a nurse, if you ask them this story, they'll tell you that every day at work is never the same. Every day is a new challenge. Every day is filled with problems or solutions that need to be brought forward by these people who work on the fly, hit the ground running on a daily basis every day of their lives. It's exhilarating, some say, it's exhausting, it's energizing, and above all, it is of great service to the people. Now, I'm joined by Irene Quah. She's the Director of Nursing Standards and Governance for RSDH Healthcare. She's here to talk about a day in the life of a nurse. Irene, thank you very much for joining us. Now, you are the Director of Nursing Standards and Governance. What does that mean?
Basically, I provide oversight for all the nursing standards, the practices in the RSDH Healthcare Group.
Right. So you kind of write a sort of an SOP for the nurses.
Yes, policies, procedures, on they like to do, and standards of care.
Right. Yeah. Well, I guess then this brings us to the next question as to how long you've been in the industry and what kind of training you first received.
Well, I've been in the nursing industry maybe around about 3.5 decades.
3.5 decades.
35 years.
Yeah, 35 years.
As a nurse on the line. I started my nursing in United Kingdom. Right. I was there about 10 years before I came back to Malaysia. And I started my nursing career in Malaysia with Subang Jaya Medical Center in 1985.
Wow. So when you came back home, Subang Jaya Medical Center was where it all started for you.
Yes, we had to do. So we helped with the commissioning of the hospital there, the operating theaters there. I specialize in operating theater. I'm an operating theater nurse. On it like to do. Yeah.
Now, when you talk about getting the basic training for a nurse, back then, I have cousins, at least 4, who've been to the UK to do nursing back in the 70s and early 80s. Now, has that changed? Do we get that kind of a training here?
I think the training is still here, what they like to do. I suppose it is different generations of it, different expectations of it, like to do different deliveries. But modules have also, we need to revise a bit to meet the generation as well. But nursing, as far as it is still the same in basic fundamentals.
The fundamentals of nursing is still the same. Now, what's life like in the ICU?
In operating theater?
Operating theater.
In operating theater. Well, I said it's challenging. It is exciting because every case, every patient presents with different types of conditions that you come in. And the most challenging thing is that to be able to assist the doctors to help them with the surgery, with the procedure. And after that, when we have got time, we go and visit the patients in the ward and to see how the patient has recovered. Right. And when you see that they've recovered and they are ready for discharge, you're so happy. It is a real reward.
So when I asked you, how is life like in the ICU, it kind of took you by surprise. Is there a difference between nurses in the ICU and the operating theater?
In ICU, it's an intensive care whereby you have got patients who are usually critically ill, are being nursed there. and they are ventilated as well
Right.
to do. The unconscious can be unconscious as well. Whereas in the operating theatre, you are doing to help with the surgery, on the more on the technical side.
So when you help with the surgery, I guess in ICU and in surgery, the one person you're always liaising with is the anaesthetist, the
Yes.
people who don't put you to sleep but preserve life, apparently. Yeah,
Yeah, they do both.
yeah, they do both. Put you to sleep and preserve life. Yeah. So you're working with surgeons, the anaesthetists, all those who are involved in the operating theatre.
Yes.
Now, what do we not know about the life of a nurse within an operating theatre, other than it's really cold in there?
Cold in there, yeah. I think basically is that people think that in the operating theatre is very technical. You know, you always see blood and things like that, but it's not. Because it's a very controlled environment, you do not see, in actual fact, you see more blood splash out in an accident rather than in the operating theatre, because it's very much controlled environment. And to be able to see all the
Okay, let's
anatomy.
let's go back in time. When you saw someone, a surgeon make an incision, a huge one, did it make you panic? Did you go all woozy?
No. Because it's controlled. Yeah, you don't see blood splatting everywhere on the like to do, no. On the it's very controlled, a very controlled environment on the like to do.
So there must be a discipline or procedures that are taken into consideration. And what does an operating theatre nurse do in order to prep for a surgery?
Well, I mean, usually you have to get the theatre ready. You look at the case that you are going to prepare for. Then you must make sure that all your instruments, all your supplies are there on it like to do. Surgical and the anesthetic and your team, they are available, they're ready. You know, and then the patient, you check the patient in as well, you know, to come in for surgery to make sure that you have got the right patient and you perform the right surgery.
But I guess also professionalism, because I remember lying on a table in a cath lab doing an angiogram, and I think the cardiologist wasn't too happy with the people around him. This was at some hospital a long time ago, and you know, he kept saying that we need to up the level of professionalism. While he's pushing the catheter in, he's talking to the nurses. I guess there's sort of a nurse-doctor relationship that goes on. Can you walk us through that? What's it like?
I suppose it's a mutual respect as well between the surgeon and the nurse, if you are talking in the operating theatre or even in the wards, anywhere else. Because mutual respect is very important on it like to do, especially from the nursing side. For a nurse, if you are being respected, you know, you are being appreciated, you are recognized, it's a boost to their morale, especially to the younger generation, to the younger nurses. And then they will perform, they're happy, they will work with you well on it like to do. For the doctor side on it like to do, yes, the expectation is that, I look after my patient, I'm very concerned with the patient care and the patient outcome. Therefore, my expectation is your nurse must be able to assist me, you know, to provide the care smoothly, seamlessly, without any problems.
Right. You know, for the years I've been interviewing a lot of people within the industry, or my visits to the hospitals, I've always seen a level of condescension where nurses were always treated like they were second-class citizens. I guess that's changing now, yeah?
Slowly changing, but can be faster.
Can be faster?
Yes.
Yeah.
I think recognition for the nursing profession is not, as we know throughout history even to now, although it has improved, is that they think that nurses is always been seen as an unskilled profession on it like to do. Like we always say, to be trained as a nurse, you take 3-4 years on the average. You go for post-specialization on it like to takes you another year. You go to degree, you do your master's on it like, which is as much or the length of time a lawyer, an engineer would take as well. So usually when you hear that, and sometimes it's very sad, when you hear that, oh, you know, oh, my son, my daughter is a lawyer, you know, is an engineer. Oh, she's
only a nurse.
Is a nurse.
She's only a nurse.
They don't say only, but say, oh, she's a nurse. So the tone, you know, is a bit different.
Right.
Yeah. So in a sense, however, there are some in the public who also appreciate what the nurses do as well.
Right. I think people are beginning to see that now, but like you said, things can speed up a little to give these people recognition. Now, professionalism in the nurse of work or within the industry, what are your standards? What kind of standards are you looking for, and how do you keep these standards in check to make sure that your people are doing the right thing at all times?
Okay. Basically, if I'm the nurse, talking for as a nurse, the expectation of a nurse, I would say that the attitude, you must have the attitude that you care from the heart, and you must have compassion. Florence
Nightingale should emanate from the heart, from within.
From within, and you must have compassion, and you take the patients for who she is on the line to do, and while the patient is in the hospital, you want to add colors. You want to make their life in the hospital, okay, as colorful, or as shall I say, in the recovery phase as comfortable as possible. Not that I'm ill, I'm in a place like that to do at all. And also the expectation is that for nurses is that you must always have a passion to continuously develop and improve yourself.
Right.
Knowledge is power on the line. With knowledge, you can translate it to skill. And if you have or skillful and be competent on the line to provide for a patient or even to assist the doctors, you are there.
What about adding as an addendum or extra training with regards to basic counseling or psychology? Because at the end of the day, when I'm lying on a hospital bed, what the nurse tells me makes me feel a little better. It comforts me.
Yes.
Right. Are these things being looked at this point to up the game within the nursing industry?
These things are up to, especially, maybe during the training can be improved, but when they're out into the workforce, like in Ramsay Sime Darby, we have a lot of training, for our nurses, in areas of how to manage patients, how to manage difficult patients, how to manage doctors as well, the type of care you must give.
Too.
So we work together as a team on it and then also to manage, you see, because now a lot of care are very high tech on it involve it. So how do you manage it as well on it
Right. Now there has always been a conversation about supply and demand with regards to good nurses within the hospital fraternity or fraternity of hospitals within Malaysia. Now, is that still a problem?
It is still a problem on it I think it's a problem worldwide as well.
Right.
What happened especially in Malaysia, the attrition rate that you find is between 17 to 20% of nurses in a healthcare industry. Now, because what happened is that there are job opportunities. Now, you see, nursing is like a borderless sort of profession. Once you're qualified as a nurse, you can move around the world to work anywhere else if you are registered with the Nursing Council of the particular country.
Right.
Now, at present, from Malaysia, we have got nurses, senior nurses, leaving Malaysia to go to Middle East, and of late to Singapore as well.
Apparently bigger money there.
Yes, and you can't help it because the exchange rate and things like that to do on. So you will lose them, but you hope that they will come back to you. Whereas as the senior ones are trained, experienced, they leave, exit the industry in Malaysia, you are recruiting the young ones. So you need time to build them on it So it's more of the skill issue that we need to balance as well than with the supply and the demand.
Right. If I were to break it down for you, and I wanted to think a little bit about this because we've got about a minute left. If there are 3 qualities a nurse needs to have, what would be these qualities? What do you look for as qualities when you're picking nurses?
Well, they're caring, compassionate, and we always say that if you look, the next quality is how will I know that they care? If I ask them that they will look after the patients as though that they will look after the family member, and I know they will give the best.
Right. So it's whether they're caring, if they're compassionate
and well, you have got the passionate, you desire to learn more,
right?
to learn and keep on learning. So learning does not stop. Even at my stage, you have to continuously want to learn, to improve, because the healthcare industry, the paradigm of change is so frequent on it, like to do. So you must be always in it to know what is happening. Then you are able then to help your co-workers or even to assist the doctors. You are able to help your patients on it, like to do.
Very interesting. So what you need in order to be a good nurse is care, compassion, and you need to be passionate about what you're doing.
You do, yes.
It was an honor. It was a total honor speaking to you. We hope to have you back again, hopefully with a few nurses sitting around us, having a conversation about their daily stories. Irene, Quah, thank you very much for joining us. Well, before we go, I need to read out an email. We get emails every so often, and this is a letter coming into us. Dear doctor, I'd like to ask if multivitamins are wasted on those who have passed 60s, and I am also thalassemic. I'm a 66-year-old female, and I'm currently on 10 milligrams of simvastatin to control my cholesterol. And here is the reply from the hospital. This is what Ramsay Sime Darby Healthcare is saying. Dear Wendy, thank you for your inquiry. Since you have an underlying medical condition or underlying medical conditions, it is advisable that you discuss with your doctor for a recommendation on what multivitamins should be taken in addition to your current medications. Please do not stop your current medications. It's not advisable for you to take any multivitamins along with your prescription without first checking if there are interactions or not, and we always want to do this to avoid complications. Now, should you need further assistance to arrange for an appointment to meet any of our consultants at Ramsay Sime Darby Healthcare, all you need to do is send us an email. So for those of you who have a question, send us an email with your problem. Send it to ask@medicaltoday.my, and we'll definitely try to get you an answer from our range of specialists working within the hospitals, and also send you a bottle of vitamins courtesy of Pharmaniaga. On that note, I'm Jared Ratnam signing off. Once again, we'd like to thank you for joining us for the past hour in Medical Today. We'd also like to thank all our subject matter experts who came in today, and lastly, Irene Quah for coming us and talking to us about the life of this group of important people within hospitals, the nurses. So every time you go to a hospital, never forget to say thank you to a nurse, because they do so much and we don't see it. On that note, I'm Jared Ratnam signing off. You have a great day ahead. We'll be back next week with more right here on Medical Today.